Thanks to everyone for joining us for this discussion regarding talking to your family about BRCA1 and 2 mutations. I'm Dr. Susan Domchek. I'm the director of the Vassar Center for BRCA at the Abramson Cancer Center at the University of Pennsylvania. We hope that you'll be able to get a lot from this session, in which myself and Dr. Allison Werner-Lin will give some preliminary slides and overview, and then we will be answering questions that have been submitted. Just to get us started, mutations in BRCA1 and BRCA2 are associated with elevated risks of cancer. For breast cancer, these risks are as high as 70% for both BRCA1 and 2, although the types of breast cancer that develop are different. BRCA1-related breast cancers are usually what we call triple-negative breast cancers that are estrogen receptor negative, progesterone receptor negative, and HER2/neu negative. BRCA2-related cancers are usually estrogen receptor positive. This has implications for the type of therapy that we will be needing to give if someone is diagnosed with breast cancer and may impact individuals' choices of their options. For ovarian cancer, the lifetime risk of ovarian cancer in BRCA1 is up to 45% and occurs somewhat earlier than in BRCA2-related cancers, where the lifetime risk is 10 to 20%. BRCA1 and 2 are also associated with prostate cancer, particularly for BRCA2, where the cancers are definitely much more aggressive. BRCA1 and 2 are also associated with pancreatic cancer, although more so for BRCA2 than for BRCA1. Of note, men with particularly BRCA2 mutations are also at increased risk for male breast cancer, with a lifetime risk of approximately 7%. BRCA1 and 2 mutations are what we call autosomal dominant. That is, that having one bad copy of the gene can be passed along to the children at a 50-50 chance. Having one bad copy of BRCA1 or 2 leads to elevated cancer risks. As you may remember, each of us has 2 copies of each gene, one on each chromosome. So the chances that this will be given to one of the children is, again, 50% on average. However, all 4 children could not inherit this gene mutation, and all 4 children can. It's a 50-50 flip of the coin each time. Now, we'll have a lot of discussion today about why we test and when we test. As a very general overview, there's a few reasons to test. One is for medical management decision-making. And for women, we start that at age 25, and we'll get into those details in a moment. And for men, we start at between 35 and 40. Another reason to undergo genetic testing for a known mutation in BRCA1 and 2 in the family is for reproductive decision-making. We're going to review options for reproductive decision-making in a moment, and this occurs when people are starting to consider having a family. At this time, we do not recommend testing children. It is not recommended because management at this time does not change when we're talking about children. And therefore, we'd like to give people autonomy to make their own decisions for this adult onset condition. We start talking to individuals at around age 18 and recommend testing for women at 25. For medical management, again, breast cancer risk for women, we start breast MRI at age 25. We add a mammogram at age 30. And along the way, we do have discussions regarding mastectomy. For men, we talk about a breast examination between ages 35 and 40. And we consider mammogram, particularly in men over 50, if there's a BRCA2 mutation, and if there's what we call gynecomastia, which is the presence of breast tissue in a man, which is not uncommon. For ovarian cancer risk, we have a discussion about ovarian cancer screening, although it's not particularly effective. And a lot of the work that we and others are doing are trying to make ovarian cancer screening better. We discuss risk-reducing salpingo oophorectomy between ages 35 and 40 for BRCA1 and 40 to 45 for BRCA2. Would state that unlike mastectomy, where we really discuss this as an option, at this time, oophorectomy or removal of the ovaries is strongly recommended at these ages. There are ongoing clinical trials regarding salpingectomy, which is removal of the fallopian tubes only, with hope that in the future we'll be able to have women preserve their ovaries for longer and therefore not undergo extremely premature menopause. Pancreatic cancer risk management is ongoing in terms of clinical trials. However, we do consider screening in those with a first or second degree relative of pancreatic cancer at age 50. For prostate cancer risk, we generally start PSA screening at age 40, and again, clinical trials are ongoing. For reproductive considerations, we do discuss pre-implantation genetic testing. This is where a couple undergoes in vitro fertilization to have screening of the embryos, and only those embryos reimplanted that do not have a gene mutation. This is an option. This is absolutely not a requirement, and people can have very strong feelings one way or the other about this, but it's important for individuals to know that this is an option available. There have been very rare cases of a recessive condition called Fanconi anemia, particularly for BRCA2. Recessive conditions are when you have two bad copies of the same gene. This has never been seen with two copies of the common Ashkenazi founder mutation, but it is something that we always take a moment and look at both sides of the family in terms of, again, reproductive decision-making. This condition is extremely rare with BRCA1, but it's, again, another thing that's part of the counseling process. As a reminder, recessive carrier testing is frequently done prior to conception for other diseases, such as Tay-Sachs and cystic fibrosis. And I just wanted to take you through, a scenario like this, which is we have a 36-year-old woman who's been diagnosed with breast cancer and is found to have a BRCA mutation. Her sister is 32, and she has not had cancer, but she's obviously worried for her sister, but also worried for herself. In this case, there's a very small family, so there hasn't been a lot of experience with cancer or this lived cancer experience until now. And we know that this diagnosis both of breast cancer, but also information about the BRCA mutation can affect everybody in the family. And we always talk about the fact that genetic testing really impacts the entire family. There can be fear for oneself, concern for others, and guilt. If you're a sister that doesn't have the gene mutation, there can be feelings of guilt. For the parents, there can be guilt that this genetic mutation has been passed along. In the setting of a newly diagnosed cancer, decisions need to be made quickly and can really feel like just a wild, tornado of emotion. In the absence of active cancer, decisions can be made more slowly, and it's important that people take the time to make the decisions that are right for them. It's important to know, and Dr. Werner-Lin will review this too, that siblings don't always make the same decisions as each other or their other relatives. And it's important that everyone is going through a process at the different times. There's a lot of questions about how to support, if you will, grown-up kids who are making decisions. Your daughter making a decision about removal of the ovaries or the breast. And there's a lot of concern about how and when to discuss with younger children. And so we're going to now turn this over to Dr. Werner-Lin, who's going to give us more information about how we talk to family members. And then after that, we'll have a panel of questions back and forth.
Thank you, Dr. Domchek. I am going to share my screen now and bring everyone along with my slides. So my name is Allison Werner-Lin. I am on the faculty at the School of Social Policy and Practice at the University of Pennsylvania, and I serve as Senior Advisor to the Division of Cancer Epidemiology and Genetics at the National Cancer Institute, where I oversee research on how genetic testing impacts families, particularly families different stages of the life cycle, which I'll talk about today. So my job today is to talk to you about the challenges and help you overcome and develop strategies for overcoming those challenges and talking about BRCA in family contexts. To set the stage, it's important to remember that talking about cancer is hard. There are challenges at the time of diagnosis or at the time of genetic testing. This can raise emotional conflicts that are new, or ones that are old can be resurfaced. It's important to recognize that in these moments, family members may be experiencing loss, and that loss can be anticipated, as in considering the possibility of a future diagnosis, loss of what they consider to be options for parenting or childbearing, and we'll talk about those a little bit more in Q&A later. And those losses are often hard to articulate. They're hard to talk about because we may not have language around that. But it's important to remember that how well we know our family history can have implications for our care. And that's an important piece of the puzzle. We do know that people are more likely to consider genetic testing and counseling if they understand their family history, if they understand that interventions are available, effective, and livable. And Dr. Domchek reviewed those with you. People who are more familiar with their family history and who have likely seen cancer up close and personal are likely to have very emotional and strong reactions to learning that they might be at risk or that they do have a BRCA mutation. And that's something to process with your genetic counselor or a mental health provider if it's particularly challenging for you. When we talk about disclosure or communicating genetic testing and results information through the family system, it's important to remember that disclosure is a process. It's ongoing. It is not a one and done type of experience. Information can be parsed out to different people at different times, depending on who you're sharing the information with, their development and maturity, their need or ability to act on the information in the present moment, and their relationship to you. So let's start by talking about what are your expectations and fears in the context of that relationship. A parent talking to a child may be very different from an adult talking to an adult sibling. And those fears or expectations, concerns about how your loved one will hear the information, will understand the information, may change the way you want to present the information in the first place. I'm going to talk about tips for setting up the scene to share and how to begin designing a script for that disclosure. People often find it easier to disclose in stages, where they start with basic factual information that they've received from their genetic counselor or oncologist, and then moving to increasingly complex information as questions are answered, resources are obtained, and comfort is established in that conversation, with increasingly wider circles of relatives included as you feel comfortable and as they feel comfortable moving conversations forward. So how do we do this? Well, there's no one right way. And that's the most important piece to take away from today. There's no one right way to share the information. The way that you share the information will depend on how your family talks about hard topics, about how open your family is to talking about challenges and fears and hopes. Does your family discuss or not discuss illness and other serious matters at all? How do they do that? That's a place where you can take note and figure out how to lead from the models that have already worked in your family system. When your family does share information about serious issues, whether they're illness related or other things that are going on in family life, because we know family life does not stop for cancer or genetic testing, is it usually in person or via some kind of phone or email chain? Now, granted, COVID changes the nature of family meetings and in-person meetings, but how do you usually do this? In live time or giving people the information and letting them respond at their own pace? Do you usually do this one-on-one or in a group? Does your family have a group chat where you share information regularly? Or does conversation tend to be between one person and one other person and then to increasingly larger circles? Does your family tend to present, or you, all of the information at once or slowly over time? Where is your comfort level there? And do you choose which groups of people to get information first and then have them responsible for sharing beyond that? Or do we gather everyone together and share together? These are just some of the ways that families talk about challenging information, and some that you can think about in your own family that have worked in the past and that have not worked as well in the past to help guide your decision-making in this context. It's important to remember that not everyone will want this information, and some people will want the information in much more private settings. So they'll want to be able to guard their own reactions or experience receiving the information freely and not worry about the reactions of those around them. So what do we tell? I would suggest when we share hard information, any kind of challenging information, it's important to practice. Before you start your conversation, take a couple of minutes and jot down some notes about what you want to say. These can be as simple as a couple of words with bullet points, or you can even write down a full paragraph and read from that if that's how you feel most comfortable. It's important that you feel prepared to share this news about your cancer risk or a new diagnosis with your loved ones and those around you. Finding the right words can be really hard. Start with the most objective information that you have learned from your doctors, from your genetic counselors, and from your test reports. Use plain language. Often I talk with families in my therapeutic practice where when they make these disclosures, they try to use the language of their that they see online. And these words are often big and hard to understand and complicated. It's best to be able to explain your genetic testing results and your cancer risk in your own words at your own pace, because that means that it's much more likely that people you're talking to can follow along. And that's really critical at this point. You can share your own personal risk of developing cancer and then inform family members about whether or not they might be at risk and what that risk is. Remember that when you first learned this information, you probably needed some support from others in terms of numerical risk. Pie charts are often helpful. And so having some of those resources can be really supportive of your family members as you share this information. To the extent that you can, it's also important in this moment to let family members and loved ones know about methods that they can use to manage their risk, such as the ones that Dr. Domchek presented earlier. This will help them adjust, feel like there's something they can do, and that kind of active coping can really support adjusting to this new information. Keep in mind that as you share information at whatever pace to whichever group of your family members, and in whatever sequence, that one size does not fit all. Different members of your family, based on where they are in their own lives, based on their familiarity with the family's cancer history, if there even is one that's known, will have different reactions and will have different needs in that moment. So best to go simple to start with, and then let the person you're talking to lead the way by asking questions, asking for more. And it's important in these moments, especially with younger children, and I'm happy to talk about this more, to go simple, answer the question that is asked. Often we try to fill in around the outsides when really there's a very specific question that our loved ones are seeking information for. And if you don't have the answer to that question, it's okay to say you don't know. And then the two of you can look up resources together. You might even have them ready with you on the computer or printouts that you can share. Family members will often, in moments of uncertainty, seek out the opinions or attitudes of those around them for support and guidance on how to react. That's going to be really important in these moments and disclosures. At the same time, because the decisions that individuals, that women and men make about how to manage their cancer risk are so personal, you might consider whether or not to share your opinion with them about what they should do, when they should test, if they should get testing. Or consider just sharing your opinion if and when you're asked. It may not be at that first moment of disclosure. It may be later in the game when they've had time to sit and think and process. And it's okay to share what you think. How do you respond? Family members will have a range of responses to learning about your risk and potentially their risk. It's important in these moments to listen, acknowledge challenging emotions. I know that you feel unhappy or sad or scared or worried or angry, and use I statements. Those are statements that begin with you. I know that when I heard this information, I felt scared. I felt worried. I felt supported by my doctors and by my genetic counselors. I was encouraged that there were things I could do to help stay healthy for you, for me, and for everyone around us. Those I statements will help ground you, help you feel safe, and give the person you're speaking with some confidence that you have been where they are now. It's important to figure out in the moment which loved ones might need extra help. This is a lot to hold sometimes. And genetic counselors and physicians and other medical professionals can answer questions and provide medical and decisional support as you and your loved ones move through this area together. If you or someone you love who is learning this information is really struggling with some deep feelings about it, you can always reach out to a mental health counselor. And increasingly, there are mental health counselors who have expertise in these areas and understand some of the issues that families experience across the range of developmental stage and family histories, to be able to support the adaptation, coping, and decision-making along your journey. Be prepared. So remember the kinds of questions that you had and the worries that you had when you first learned that you were at risk. And you can anticipate that your family member might have similar concerns. It's most likely that you are not a genetic counselor. I am not a genetic counselor either. I'm a social worker. And so I don't answer medical questions. That's not my expertise. So when people have medical questions, it's important that we direct them to the right person to get the right kinds of answers and information. Who to tell? Here are some things to consider as you move through decision-making around these conversations. Different members of your family will be differently impacted by this information based on their age, where they are in their life, and kind of how they envision their life moving forward. And we'll go over this in a minute, thinking about stages of individual development and where we are over the life course. How much do your loved ones, or the ones that you're talking to in the moment, understand about your family history and understand about genetics? We don't need to know a lot about genetics to understand cancer risk, but it's important that we understand percentages and some of the other numbers and risk management options that are available. This information is going to have different implications for different family members, and I'm going to talk about that now. Now, there's a lot of information on the slide, and I've broken one of the cardinal rules of PowerPoint on this slide and the next by putting just too much text. So bear with me for a moment. This is a basic overview of some of the primary issues that kids face, that your children will face as they go through the life cycle in the context of a family where there has been a cancer diagnosis or several, or where there is known cancer risk. And this is intended to help guide your thinking about how and when to tell your children. I do encourage conversations starting early, and we can talk about that as well in a little bit. In early childhood, often children don't understand genetics really at all. What they do notice is human difference. They know that their eye color or their hair color is the same or different from people around them. They notice things about height and identify characteristics that they share with parents and siblings. When someone in the family has cancer at this stage, children are often concerned about separation, because even young children don't necessarily understand what is going on, but they do get a sense of the emotion, heightened emotion in the home. In middle childhood, middle school years, kids are great information seekers. They know how to go into your email. They know how to check your messages on the phone without making it look like they did. They're super sneaky, but they're really not great interpreters. And up through most of the life cycle, kids are much more likely to take responsibility or to feel like bad things happening in the family are a result of their actions. We call this magical thinking. And so it's important to understand that kids have likely noticed that something's going on in the family, and be prepared to share that information with them so that they know that they are not to blame. And give them some information about that risk. In middle school, children are great when they are presented with very concrete visual images and numbers. That's where their brains are at that point, and that can help them understand risk. As children shift into puberty and adolescence, they often begin to develop secondary sex characteristics like breasts, pubic hair, underarm hair. And if there's been a history of breast cancer in the family, that development can lead to a lot of concern. It's important to talk with kids at that age about those concerns. And if you're not comfortable with that, which many families aren't, it's okay to consider seeking out mental health support. Later in adolescence, we've heard from a number of kids in high school that they've learned about genetics and inherited diseases in their science classes, in biology, and other courses in school, and then have kind of made the connection that something's going on in their family. We'll get back to this, but it's important that kids learn from you first. Kids at this age have easy access to information over the internet. And parents, you may be very concerned about their screening and health behaviors and how to help them plan for their futures in ways that maintain not just their physical health, but their mental well-being at the same time. And then we have emerging adulthood. These are those ages during college or early working years where Your now adult children are exploring their identity, figuring out how to have lifelong partnerships, exploring their independence, but most critically, considering lifelong decisions and have the capacity to think about how those are going to develop over the long term. At this point, they may be considering having families of their own, considering parenthood and making space for small people in their worlds, and parenting, and then parenting children and adolescents. And I want to talk a little bit about how to discuss these issues with children particularly. Learning we have a parent learning that they have a BRCA mutation is so distressing, or can be so distressing. And one of the pieces that parents often say is of significant concern is how they're going to share that information with their children. Before you begin discussing this information with your children, it's important to get your head around what it means for you and how you're reacting to the information so that you don't put that reaction on the table for your child. You want to be able to present confidence, answer questions, and respond to what your child needs in that moment. A parent who has not yet come to terms with their own test result is less likely to be able to communicate that information well to the child and respond to their child's needs. Also, it's important to consider disclosing before your child reaches the age of 18. Dr. Domchek talked about in the medical setting, 18 is the age at which they begin discussing BRCA testing, but conversations about genetic risk can happen much earlier than that in family life. We've often heard from young adults that they would have preferred, or they really appreciated that their parents started talking with them before decision-making was on the table for them in the medical setting. This helped preserve trust, keep conversations open, and strengthen relationships between parents and adult child. Remember that disclosure with kids is an ongoing process. And so a little bit of information when they're younger, moving to older children and through adolescence and into adulthood may be the best way to help them understand and let them come to you with questions as well. It's also possible that in families with children across different age groups, you're going to need different language. It may be feasible to sit children down to start the conversations around risk together or just around genetic difference together, but then separate children according to what they're interested in, their personalities, their ages, their developmental stages, and continue the conversation in ways that meet their developmental needs. Along the way, it's really important that you seek support for yourself. Discussing BRCA is more about than educating each member of your family about cancer risk. It's about coming together to face a shared challenge. It's about seeking support for the decisions that you're making. It's about helping others emotionally to cope with and make decisions that are good for themselves. And not just about their medical care, but about having children, telling lifelong partners, and making decisions that help keep them safe. It's important in this context that though BRCA risk, inherited cancer risk may be shared, the same course of action may not be right for everyone in the family. I've worked with families in my practice with siblings across many, many years where all have tested, or many have tested positive, and the oldest, done with childbearing and ready for prophylactic risk-reducing surgery, has put pressure on the youngest, maybe still in college or just graduating from college and not yet ready to make lifelong decisions. It's not a matter of that individual not deciding not to have surgery or not to do risk reduction, take into account risk management reduction. They're just not ready yet. So we can think about risk management as a process, and the conversations about it, just like disclosure, is a process. It's also possible in those moments for you to attend to your own needs and for you to attend to the other's needs and for them to take care of you once those conversations are ongoing. What happens if you disagree? Well, family conflict is normal. I've never met a family that didn't have some kind of conflict somewhere in their family system. Sometimes it's about illness and sometimes it's about a million other things. But those conflicts can be brought back up to the surface as challenging subjects come to light in family systems. It's important to identify, what are you disagreeing about? Sometimes small hurts can feel really, really big. If people feel like they've been excluded from information or haven't had access to information, or that conversations have begun without them, or that they even know about this information in the first place. Once you identify where the family has disagreed, where there's been anger or hurt, you can communicate directly with that individual. And this can be hard, especially if that's not normally how your family communicates. I want to distinguish now between secrets and privacy, because this is something that we often see with families, where secrets are have impact for others, but privacy is about information that's just about you. So what you decide to do with your cancer risk may or may not have implications for others around you. But that risk is something that could potentially be shared and have implications for others in the family. It's possible in families to identify solutions to problems with communication or to consider risk management as something that you can do together. I've worked with families who've decided all to go get their screenings and then go out for lunch the same day every year. And it's a way that they share that challenge. Other families struggle with the emotional intensity of that. And so everyone goes at their own pace and at their own time. In that way, it's important to balance individual decision-making and interests with a sense of connection and support for each other. It's important to remember finally that you do not have to do this alone. There are providers in your area and here at the University of Pennsylvania who can help you learn more about risk, support disclosure to children, to other family members, support you and them in coping with this information, and provide you with resources for how to talk and cope with having a BRCA mutation. I am going to stop sharing my screen now, and we will bring Dr. Domchek back so she and I can have a conversation with you. One of the things that I hear a lot in my practice from families is, I have a child who is 21 and is interested, knows that I have a BRCA mutation and wants to get testing now. What do I need to be thinking about? So Dr. Domchek, can you tell us from the medical perspective, what are some of the things that that family and that newly adult child should have in mind at that age?
Yeah, it's a great question. And we, as you've heard, we often talk about starting medical management at age 25, but that doesn't mean we aren't willing to discuss or even test adults. Adults are able to make their own informed decisions about this. So although we don't test children, but once someone is an adult, if they're asking a lot of questions, we usually say, bring them in. Let us have a discussion with them. We have them meet with a genetic counselor. This is an area where I think genetic counseling is incredibly, incredibly helpful, is to try to kind of put forth, what this all is going to look like and what it would mean to test positive and yet not do anything. So if you're 21 and you test positive and you're not going to do anything, what's that going to feel like to you? And there are some people who really feel so strongly that the anxiety of not knowing whether or not they had the gene mutation is such that it might be the right thing for them to get tested. For most people, it's not. I'm going to be honest with you. Because thinking that you might have a mutation and having a mutation can be extremely different things. But we really try to take people through that. And we even sometimes have individuals who are 25 who really are not ready emotionally to get tested. In that case, if there's a known mutation in the family and mom or dad, we'll start screening without testing. So, so we work with people to try to kind of meet them where they are in terms of, how they're going to respond to this information emotionally and practically.
The idea of meeting patients where they are is one of the core tenets of social work practice too, is entering into their concerns and considering where they are in their lives and when they're ready for things. And that kind of approach can be really helpful on the coping side as well. At the age of 21, we think of young adults as fully ready to make lifelong decisions, and some of them are, but some of them aren't. We know that brain development hasn't quite finished yet. The ability to think about the lifelong implications of these decisions aren't quite there yet. And there can be some impulsivity to address that anxiety, the desire to know right now. But without action steps beyond that, it can be quite a challenge to live with the information without really being able to do much about it. Also, at the age of 21, family providers are often shared. So family histories are known by their providers, and young adults may be coming into those practice settings and hear their family history laid out for the first time, and it can incite fear. So thinking about all of these things as processes that can build up over time until that young adult is ready is important. But as you said, and as I said too, having conversations much earlier than that about genetic difference, about disease, about different members of the family who've been ill and connecting the dots that there has been risk, those conversations can start much earlier. And I'll give you the story, and this may be helpful to some of our listeners. I trained in a community cancer caregiving setting. So we provided support groups for families who were impacted by cancer. And we had a 14-year-old girl in one of our groups. And after her mother had breast cancer, and unfortunately her mother died. But when they were cleaning out her mother's no known BRCA mutation or any kind of genetic mutation at all in the family, when they were cleaning out her mother's books, we thought that was wonderful, that she would take some of her mother's books. And we asked her which books she had kept. And she told us that she'd kept all the breast cancer books. And she was 14. So she was already seeing that this was an eventuality for herself. And so part of our balance with her was, this is not your pathway through the future. This was her path. There may be parts of it that are shared with you, but the take home there for us was kids are seeing what's happening around them and applying it to their own lives without giving us an opportunity sometimes to be able to teach them about how these things work in a medical space.
I would really agree with that. I think that, teenagers hear about, my kids have heard in biology class about BRCA 1 and 2, and then come home and say, don't you know something about that? So it's amusing. But they're hearing about it and they're smart. And so they put together sort of the family history with this. And I'm sure we'll talk about that a little more. One thing I wanted to follow up on is the other thing about, say, a 21-year-old, and I may be putting this too bluntly, but they're in this era of exploring their sexuality and sort of simultaneously telling them, basically inferring that, your breasts and your sexual parts are going to kill you at the same time when they're in that stage of maybe exploring their sexuality is really tricky. And so we also bring that up. I mean, we don't really need to know this information because we're not going to act on it. And, this is such a pivotal part of time in their lives when they're sort of working through all that. So that's kind of another element that I just wanted to bring up.
Thank you for sharing that. Absolutely. And that can start with the development of secondary sex characteristics of breasts. I've heard young women really scared when they start to develop breasts. And it's okay to enjoy those parts of your body. They're going to be mixed. It's going to be, it might be a mixed bag for a while as they work through what it means to be a part of a family that has genetic risk for breast cancer, for ovarian cancer. But it's okay to have that exploration and to have that be a separate part of their world and their identity than the family's genetic risk.
And you wanted to also, we started to talk about, the teenagers. And so teenagers are fascinating to me because again, they are hearing, they are listening, they are smart, but they also are not always the best communicators. And so, what I hear a lot of, and I really love your perspective on this, is when things are brought up, even, they often just need information in bits and pieces. I think that our tendency as adults is to sort of provide the full lecture when they want 5 minutes today and they want 5 minutes next week. And I think that that's hard for people because once the doors open, they kind of feel like everything has to be said sort of right then. But it really seems to be more effective to space it out.
Absolutely. So one of the things I talk to parents about is answering the question that the child asks, and then letting the child lead the way. Now, the caveat to this is that often when children sense that something big and emotional is happening in family life, if they are not brought into that conversation, they often feel like maybe they're not allowed to participate in that conversation, or information about that is taboo. It's not to be discussed. So it's important for parents to let kids know that they can ask questions and they can participate in conversations, and that what's happening in the family isn't related to anger or anything about them. That said, children often ask very specific questions, but they don't always say them in the right way. Another example from my clinical work, we had a young boy who, when his mom was sick, kept asking who would take him to his doctor's appointments. And he said, oh, dad will take you or grandma will take you. But what he really wanted to know was who was going to take care of him. It was a bigger question. So sometimes it can be helpful for parents to sit and think for a moment, what is my child really asking me? And to answer that question. And you can even, as parents of younger children, teenagers, older adults, ask children what is it that they're really wanting to know, because they do often have trouble articulating what it is they may not even know what it is they actually want to know. But sitting down and having a conversation and answering that question with a question, which some teens will find incredibly frustrating, I'm not going to lie to you about that, but to say things like, is there something specific that you're worried about right now? Or did you hear something at school that made you think about our family? Or things have been a little tense around now. Maybe you're responding to that. And ask them what it is that they have seen or heard, so you know exactly what the question is that they're asking. Otherwise, we might wind up giving them information that they did not ask for and that they're not ready for.
Right. I wanted to give another example of that, because I think when we're really specific, it's helpful. On the other side, I had a patient of mine talk about how her father had died, and her child kept asking where grandpa was. And so she was just trying to navigate this. So, well, some people believe in God and all this kind of stuff. And he just kept asking. And then one day a friend of his was over, and these kids were 5. And the kid turned to him and said, well, your grandpa's in the ground. And the child said, oh, okay. And that was what he was asking. So, sometimes we think that sometimes we think they're asking a small question and it's a big question. And sometimes we think they're asking a big question when it's a small question. So really trying to get to the root of that is important. And, we deal with this, our cancer patients, all the time. There's opportunities there. So, when a woman is diagnosed with breast cancer, she's losing her hair, she's talking to her kids, and she might have a genetic risk. Opening that up, what questions do you have? And it's not infrequent that the kids will say, do I have to worry about this, right? And maybe we'll get into this a little bit. It's important not to lie either. And it's really easy to lie. It's really easy to say no when what mean is not now. And I think the words are important, because when kids feel that they've been lied to, even if it was for their protection, that doesn't usually end well. So can you comment on that?
Sure. And the first thing I want to say is, because some of the parents have written in and said, I haven't told my child yet. I'm planning on telling them later. It's never too late to start having those conversations, and you don't have to wait for your kids to initiate these conversations. If you feel like, oh, I may have misstepped there, I may have made a mistake, it's okay to go back and say, a couple of months ago you asked me this question and I answered this way, but I want to talk to you more about your question, and revisit the conversation. And that can reestablish those open lines of dialogue. That idea about making sure that what you're telling them is the truth, but also appropriate to how old they are, what they can understand, is really important. We often have mechanisms to protect ourselves emotionally and spiritually that make sense for us, but for a child who understands the world in very concrete ways, those things that we use to help us get through the day don't work for them. So we often tell the children in that situation that grandpa's in a better place, or he passed, or he went into a long sleep. Those are things that help us, because they're taboo conversations. They're hard to have, but they can be very confusing for a child. So using a very concrete, specific words and language can be super helpful in those moments.
Right. And things like, that, yes, there is genetic risk, but there's nothing for you to worry about right now at your age. There is no impact. Or, when patients of ours have cancer, frequently the kids will say, are you going to be okay? And, that's a hard question. And so again, you can give better words, Allison, but usually, my suggestions are, my doctors and I are doing everything we can to make sure that I stay healthy, which is still a very positive, affirming statement, but it's not brushing it off, because these kids can feel betrayed when then something bad happens. And of course, this is developmental. They can't process this type of information. So
that's actually exactly what we encourage parents to say, is that the doctors and I are doing everything we can so that I can get better. so that I can get better and be here. And it's important for those conversations to start so that kids can then feel like they can ask questions. Well, will you tell me if something changes? How long is this going to take? And the same is true of recovery from risk-reducing surgeries. If someone decides on mastectomy, to understand that small children are going to have trouble understanding that there are parts of mommy's body that are in pain right now. There are parts that mommy is tired, that daddy is a little more frazzled because he's taking care of more things around the house, that it's okay to talk to kids and give them language around these issues so that they can feel like they're a part of family life in a really important way.
Another, question that was recurrent was how to navigate when your family members are making different decisions. And I think this is actually a really important element. So how do you counsel those families?
So the first thing is to remember that the decisions that we make are personal for a variety of reasons. We make different decisions from our siblings, from our cousins, from our parents, based on how we envision technology will or might change, based on what we can afford financially, or what space we can make in our lives for treatment, based on where we are in the life cycle. Someone who feels like they have completed having children, they are no longer using their ovaries, may be much more open to talking about having them removed for cancer risk prevention than someone who is younger or who is feeling like they haven't met the right person yet, or they're not sure how to proceed with those decisions. So it's important to remember that risk management really is on a trajectory. One of the places where I do see a lot of disagreement in families is about testing it all, where one sibling decides to test and another sibling does not want to even know about the risk in family life. And this can make it hard to talk about. This piece can make it hard to talk about everything, because often the person who knows they have a BRCA mutation feels very responsible for sharing the information, for protecting people around them, even if they don't feel the same risk or urgency. So I want to go back to something that you had said earlier, which is something I talk to about when I teach genetic counselors and when I teach social workers, which is the distinction between important decisions and urgent decisions. These are very important decisions, but not all of them have to be made right away. As women age, as men age and are in the windows where their risk increases, it becomes increasingly urgent. But there is a timeline that is different for each of us to adapt and adjust to the information and to be ready to act on it. And for some, genetic testing is about learning one's risk, and for some, it's about making the decision to shift from screening regular mammography early to considering risk-reducing surgery. So the different ways that we use risk information, the different ways that we process our own health and our own what we're ready for in terms of considering our health are really critical in those conversations. When I can, I'd like to have people together, but if I can't get everyone together for a conversation, so that what often happens is that there are emotional wounds that go with offering information and feeling like it's been rejected. And then that person who has made an effort to communicate that risk feeling rejected as an individual, as opposed to a communicator of risk information. That person's the messenger. And we know that who is the person that gets shot in family life? It is the messenger. So it's a tough role to be in. It's a tough role to be the first person in a family system that knows that you have this risk, and then feel the responsibility to share that with those around you.
And to follow up on that, it's really your genetic counselor or the genetics clinic that you go to should have information and things available to you to help. So for instance, we have written information that will provide like template letters that will give people to share with their relatives and other sort of ways to do this. It's not as you alluded to earlier, there's many different ways to communicate. And sometimes people might start with a phone call and follow up, with a piece of mail that also has resources on it. And then they can feel like I did what I needed to do, which was communicate that this is important information, and then be able to kind of walk away from it, because it can't be all in one person. You can bring a horse to water, you can't make them drink. And, you can only try so hard. I think the other place where we do see conflict is, I take care of plenty of families where there are sisters that all have mutations, and the remove the ovary decision, tends to be a more straightforward sometimes. Not an easy decision, don't get me wrong, but the medical evidence is such that we're much more pushy about that decision. But the mastectomy decision is very challenging, and people really view it very differently. And I had one family where they finally got to the point where one sister was pushing so hard that everyone had a mastectomy that they had to agree not to talk about it at family events, because there were 4 sisters, and it was just sort of, they just felt barraged, and they felt like every birthday party and Thanksgiving was taken over by this conversation. And so I think that there is kind of a time where, as a family, you can call a timeout, and you can just say, we all have this information, we all are seeing physicians, and we're all making our own decisions. And it's tough because you want to use your family as support too, but sometimes family isn't supportive. So.
And one of the things that we've learned is that family support and family influence can be experienced as support sometimes and as coercion at other times. That the intent is wonderful and supportive and in the service of keeping everyone safe, but that's not always how it's experienced. Another scenario where I've seen this kind of distinction, and oh, sorry, I wanted to go back. One of the pieces that I do advise families in that situation where these conversations can be anytime, anywhere, and people are kind of always on edge, is to find a place for the illness in family life. So that it's not the dinner table. It's a conversation where you sit down in the living room. My kids know that if I bring them in here, which is my clinical therapy office, that we're having a big conversation, right? So when they come like, guys, come on into my office, they're like, uh-oh, what happened, right? What did we do now, or what's going on? So, but having that space means that they feel safe in the rest of the house. They know nothing big is going down in the rest of the house. We can just be in our family life together. But having this space, kind of carved out for the family meeting, for that hard discussion, and it can be anywhere in that family's, that extended family's life, maybe a parent's house, the sibling, inviting people in to participate in that conversation and then finishing it in that space can be super helpful, because it means that they can then go into the other parts of their lives free of this. So they've put the illness in its place and it stays there, and it doesn't have to take everything over.
So one other thing that came up, and we'll come to a close soon, it was the question of why 25. So I just wanted medically to talk about that a little bit in terms of testing, not discussion, as we just reviewed. Discussion can happen at any time. There's not a zero risk of anything in life, but the risk of developing a breast or ovarian cancer before age 25 is as near to zero as we can get in medicine. So again, I'll never say zero, but it's extremely small. And we also think it's important to talk to people about decade-specific risk, is how we call about it, or your risk in the short term and your risk in the long term. So people hear that 70% lifetime risk number and think that therefore I need to get a mastectomy, tomorrow, because that risk is unmanageable. And we really try to say, what is your risk this year, this 5 years, this 10 years? And to give some perspective on that, for BRCA1, where the cancers can occur earlier, still by age 30, there's a less than 5% chance that those women are going to develop breast cancer. And when you kind of say that to a 25-year-old, I can often just see them relax, because that number feels fine. And of course, their risk is much higher than the average 25-year-old, but that number feels workable. It feels doable. And so we really do try to communicate that information. And I'm sure you've seen this, you already mentioned, Allison, that it's kind of age specific and time in your life specific, but certainly, women feel very differently if they are in a stable partnership and feel, and are not sort of mid-dating, because that really is hard during all this.
Absolutely. Communicating with potential partners about risk really challenges the start to romantic relationships. So one of the things we've learned is that young adults who are in stable relationships, when they learn about their risk or they learn that they have a mutation, are already known kind of by their partner as a full whole being, that this is one part of the full package. But there's been publicity, there's a documentary about this out there called In the Family that Joanna Rudnick made with Cartem Twin Films, about how do we disclose this to new partners? Is this a first date thing? Is this a second date? Is this a third date thing? Do I wait till they're locked in? Like, how do we work this? And how do I, from their perspective, how do I tell someone in a way that it assesses whether they're able to tolerate it and be in this with me and not terrified and run off. And I got no time for that person who's going to run off. So there's a lot of pressure on early relationships. And for that reason, sometimes people don't want to know at that stage. Or there are opportunities that it changes who they're looking for in a partner. It changes, you know, and that's not necessarily a bad thing. You want someone who's going to be with you through the good and the bad and the ugly and everything in between. But there is an impact in this space. It does impact sexuality and conversations around childbearing and being connected to family, to parents, aging parents, and siblings who may also be at risk.
And I think that we try hard in the medical profession, and family members do as well, to, you know, to emphasize how this information can be valuable and can help prevent disease, you know, potentially, you know, improve survival. And those are all very positive things. And we hear knowledge is power. But I do want to take a moment to sort of just also say that it also, excuse my language, sucks. And that that when we're kind of, when families are talking, you know, you always have to take that moment to just acknowledge just how yucky this is, and how 25-year-olds, most 25-year-olds don't have to deal with this, and it's a hurt. And so, you know, one of my patients said to me, and it always stuck with me, you know, she said, "It saved my life and it ruined it." And sort of, you know, it's this tension between those two, which, you know, we on the medical side are trying to come up with better choices so that these aren't the things that people have to decide. But at the same time, you know, having that moment of grieving, and I'm sure you can speak to this, there's a grieving process with this information, because it's hard, and it means that the trajectory of life is going to be different, even though it is potentially life-saving and incredibly valuable.
So we call that anticipatory loss. It's the loss of things that are still yet to come. So, and it might be grief around how you envisioned having children. It might be grief around how you experienced having, finding a romantic relationship. It could be grief related to your identity as someone who is healthy. You know, even though there's no way to know in that moment how being at risk will play out over your life course. And one of the ways we back this up for families with young kids is by talking about health behavior early in life. That when we go for our annual physicals, we let kids know that we're going for our annual physicals, so they understand that those checks to stay healthy are a regular part of family life. When we take kids for their inoculations, their vaccinations, when we go for walks after dinner, when we engage in any kind of health behavior, whether or not it shifts risk, it's a way to start conversations around health and gives kids tools as they grow up through the life cycle to feel like they have some control over their bodies. And that's a kind of coping mechanism that we're learning across different kinds of cancer syndromes can be really helpful in regaining some of that sense of this doesn't have to ruin my life. Because it does suck. It's really horrific. And it's at a time in the life cycle, we don't expect cancer to be on the table. We don't expect to be thinking about this in our teens, in our 20s. We think cancer is something that happens to older people, but that's not what this community listening today knows and understands about the world. So those kinds of health behaviors, having a conversation around health and well-being really globally, not just our bodies, but our minds and how we're coping in our environments, can give kids of all ages and parents tools to begin having conversations about how to stay healthy, how to make sure we're healthy, and when we're not healthy, how to make sure that we see the right people to help us get better.
And I think that this has been such an incredible conversation, and I so appreciate it, Dr. Werner-Lin.
Thank you.
I want to end on, you know, this note as a reminder. In a little over 25 years ago, we didn't have these genes cloned, and since that time, we've come up with ways, not great ways, but we have ways to significantly reduce cancer risk. We've developed targeted therapies. We've got lots of things in the pipeline for prevention. So our goals are that this knowledge will be so valuable because you'll be able to prevent cancers without having to have these surgeries. So there's a tremendous amount of hope that this isn't going to be the continuous path in the future. But for now, you know, we just want you to know we're here. We're here for you, and there are a lot of resources. And so we thank you for your time and attention. And again, thank you, Dr. Werner-Lin.
Thank you for having me. Take care, everyone.